I'm very pleased to be able to introduce our keynote speaker, Laurie Robinson, Assistant Attorney General of Justice Programs at the Department of Justice. Laurie has a very impressive resume, and I could probably spend the rest of the hour reading through it. So suffice it to say that I'm only going to give you some of the highlights. She was sworn in as Assistant Attorney General 1 year ago and previously served in the same capacity from 1993 to 2000. In the interim, though, she kept pretty busy, serving as Director of the Master of Science program at the University of Pennsylvania's Department of Criminology, as a distinguished senior scholar in the Jerry Lee Center of Criminology, and as Executive Director of its Forum on Crime and Justice. Currently, Laurie oversees an agency that provides leadership to federal, state, local, and tribal justice systems. Most important to our conversation is that she understands the connection between public safety and public health, and her strong leadership will be invaluable to moving this discussion of connectivity forward. Because Laurie is on a very tight schedule to catch a plane, she unfortunately will not be able to take questions. However, we are incredibly grateful that she is here today on such a busy day, and that she made it a priority to be here today, which again speaks volumes to her commitment to these issues before us. So it's a pleasure to introduce Laurie Robinson. Please join me in welcoming her.
Nancy, thank you so much, and good morning to all of you.
Good morning.
I look around this room, I see a lot of very familiar faces here, and I was really impressed looking through the list of attendees for this event. Again, I saw lots of familiar names on that list, but even more than that, kind of the breadth of attendance here across the criminal and juvenile justice systems and the public health arena. And I really want to thank Robert Wood Johnson and the Langloth Foundation for putting this together. It's an incredibly important meeting. And my tremendous thanks as well to Cochs for organizing and hosting this event today. Again, I think it's an incredibly impressive group of people, and I know these discussions are going to be incredibly thoughtful and, I suspect, very, very productive. And I'm pleased to be part of this conversation about the intersection of health reform and public safety. The provisions of the Patient Protection and Affordable Care Act, I think, do provide really an unprecedented opportunity, as you're saying here, to rethink correctional health care. Now, I've been concerned for a long time, and I saw Don Murray asking a question, and he knows how long we've been working in this vineyard, concerned about poor inmate health, not only for the inmates themselves and the institutions where they're confined, but because of the impact more generally on public health and also on public safety. This all ties in together. Correctional health care is a public safety issue, and I think the broader public doesn't truly understand that. Before I came back to the Department of Justice in OJP, I had the privilege of serving on the Vera Institute's Commission on Safety and Abuse in America's Prisons. And I saw Alex Buzansky in the back of the room, who was executive director of that commission. And he knows that in the testimony we heard from corrections officials, former inmates, and other experts, we heard very troubling accounts that had to do with health care, or the lack of it, in institutions around the country. And those anecdotal accounts are, of course, backed by statistics. We can look back, for example, to a 2002 study by the National Commission on Correctional Health Care that found that every year more than 1.5 million people are released from jail and prison carrying a life-threatening infectious disease. An earlier study found that those who pass through America's correctional institutions account for nearly a quarter of the general population living with HIV or AIDS, almost a third of those with hepatitis C, and almost 40% of people with tuberculosis. On top of these physical ailments, as you know, a disproportionate percentage of people with mental illness cycle in and out of jails and prisons. And a study from our Bureau of Justice Statistics based on surveys of prisoners and jail inmates found that 16% have a history of mental illness. That means that well over 1 million bookings of people with serious mental illness may occur every year in this country. And what's so frightening is that only 18% of those inmates report receiving any treatment after admission. For years now, as all of you know, it's been observed that detention facilities are the new asylums. But unfortunately, these new asylums are ill-equipped for that role. And then there's the problem of substance abuse, as I don't think I need to tell anyone sitting here in this room. Data from BJS tell us that more than half of all state inmates were abusing or dependent on drugs in the year before their admission to prison. By way of comparison, the last published national survey on drug abuse and health from SAMHSA found that only 9% of the general population was classified with substance dependence or abuse in the prior year. And we know that few who need substance abuse treatment in correctional institutions actually receive it. And I suspect those numbers are going to go down with the current budget crises facing municipalities and states. So these statistics explode the notion that prisons and jails are sealed institutions. We know better. Almost everyone who enters a prison or jail will eventually return to his or her community. Many in a matter of days and weeks, not years. And in a vast majority of cases, the time spent behind bars is not a period of physical or psychological rehabilitation, but rather an invitation for an illness to entrench its effects. In terms of scale, we know that some 735,000 people come out of America's prisons every single year, and 9 million cycle through our jails. Given these large numbers and the high percentage of inmates and detainees with medical, psychological, and substance abuse problems, we are dealing here with a potentially serious public health as well as public safety issue. To my mind, dealing with this problem requires looking at the issue of correctional health care the way we look at all aspects of reentry, namely that reentry back into the community begins the moment an offender enters the system. That means, as we heard from the prior speaker, early screening and assessment to detect and identify core health issues, appropriate institutional treatment, and continuity of care in the community. Sounds easy, right? And if the challenges I outlined earlier weren't enough, let's not forget, as surely you have not, that these are deep-rooted problems that weren't created by the corrections system. We know they were not. As we put it in our report for the Vera Prison Commission, many of the biggest so-called prison problems are created outside the gates of any correctional facility. Dr. Vasey points out in her paper that these offenders are disproportionately poor and have high rates of health problems, psychiatric disorders, and addictions coming into the system. I like the way she put it. If I can just quote from you, Dr. Vasey, upon booking, arrestees are often at their sickest. Prisons and jails inherit the medical, psychiatric, and addiction problems of those over whom they have custody. And despite the resource challenges and the large numbers of inmates and detainees needing help, some of those institutions have done commendable and even stellar work to reverse those problems. It sounds remarkable in the face of the obstacles, but in some cases, people actually return to their communities in better shape than when they left them. But in these cases, the health gains are often squandered without continuity of care or adherence to the treatment regimens. I think it's essential that we figure out how to scale up the model being implemented in Hampton County, Massachusetts, and the Cochs sites. Now, with the enactment of the Affordable Care Act, I think we have an incredible opportunity to build on those pockets of progress. As you well know, access to health care services in prisons and jails has always been a complicated issue. Those who are incarcerated have a constitutional right to health care. Yet federal benefits are either suspended or terminated when a person goes behind bars. This leaves the burden on the institution to provide care, and the resources for meeting this responsibility and the commitment to do that we know vary widely among jails and prisons. Then there are pretrial detainees, those who haven't been found guilty of a crime and aren't legally precluded from receiving benefits, yet who still find themselves effectively excluded from care. These detainees make up the majority, we know, of the jail population. Many of them come into the system, and no sooner have they been processed and admitted than they're back out again, except that now they don't even have the means to access basic care. So, of course, what happens is that they rely on emergency rooms and other urgent care for treatment. And we all know that that's really, really expensive, and the cost of it falls squarely on the taxpayer, not to mention that it's not a very effective approach in the long run. The new health care law gives us an opportunity to address what I think is the biggest challenge in correctional health care that we've been talking about this morning: continuity of care. By 2014, the obstacles to coverage may be eliminated for detainees, and so community-based providers will have an incentive to work closely with jails and prisons to serve the needs of their population. We've already seen good examples of this kind of collaboration, most notably, of course, the Hampton County model, which matches inmates with treatment providers based on the inmate's home zip code so that treatment can continue uninterrupted after release. This kind of connection is so important because even where good institutional treatment is provided, it often, as we know, falls off at release. Fewer than 20% of annual jail admissions stay longer than 1 month. So this continued community care is paramount. Now, I think, now is the time to be building these partnerships. As the Hampton County experience demonstrates, there's nothing to prevent us from developing these relationships right now. In fact, there are more than 1,200 federally qualified health centers serving some 6,600 communities that are designed to meet the medical needs of underserved populations. And many of these centers are already working with correctional institutions. To other providers, I think we can make a strong case for working together based on the potential public safety impact on inmate health and on cost. Partnerships are key to meeting correctional health care challenges, but I don't want to sell partnership as a panacea. We know that resources across the board are scarce, and even a strategic pooling of resources can't be expected to solve all of our problems. I think we also need to set some priorities and not expect that we'll be able to achieve community standards of care for every inmate or detainee in every single case. This, I think, begins with a quick screen, followed by thorough assessments of risk and need. We know that assessment is one of the pillars of any public health approach, but it's even more critical in the corrections arena, particularly given the often short jail stays of many of the people coming into the system. In many cases, assessment may be the only interface with correctional health care. In these cases, assessment serves to identify who needs treatment services on the outside, and it identifies what specifically needs attention in that treatment plan. Risk assessment, even beyond medical and psychiatric issues, is the bedrock of effective reentry. And I feel compelled again to point out that from a public safety standpoint, correctional health care is very much a reentry issue. I think we need to let risk and need help us sort out who to focus our resources on. This means universally screening inmates and prioritizing who gets services. Also, there are basic administrative obstacles to continuing care that have to be addressed. Reinstating Medicaid benefits, for example, as you know, can take months. And so those who are very ill at admission return to the community with no coverage, at least for the short term. But there's nothing preventing correctional agencies from working with Social Security offices to ensure that benefits are reinstated when an inmate is released. In fact, SSA has pre-release agreements now with about 700 state and local prisons and jails. This could and should be part of discharge planning so that returning offenders can begin to receive services immediately upon release. Now, I know these are complex issues, and resolving them will require a lot of strategic planning, as well as changing attitudes, which I know is sometimes the biggest challenge of all. I think we at the federal level have an important responsibility to help lead this shift. One thing we're trying to do is do this through an interagency reentry working group. OJP, my agency, is leading this staff-level effort, and my boss, Eric Holder, will be creating a parallel cabinet-level group. The issues you're discussing here and that are set forth in the papers that were commissioned for the conference are really going to be useful in helping inform those discussions. Two of my staff who are here today, Marlene Beckman and Amy Solomon, are heading up the staff-level group, and I think there are several people from some of the other agencies involved in that who are here today as well. I know that Amy and Marlene have been talking with Nancy and Steve about the issues under discussion today, and that's been very, very helpful. Back in January, I spoke to the American Correctional Association's Healthcare Professional Interest section. And I pledged at that time that this administration and the Eric Holder Department of Justice are committed to improving the healthcare delivery system in this nation's correctional institutions. This reentry working group across the government is evidence, I think, of that commitment. We're moving forward in other ways as well. Last month, the Attorney General announced $100 million in awards under the Second Chance Act to support 178 reentry grants nationwide. This is on top of 70 reentry grants we awarded last year. And some of these focus specifically on health care in our nation's jails. A good example is the Allegheny County Jail Collaborative in Pennsylvania. This is a partnership between the jail, the County Health Department, and the county's Department of Human Services. Inmates are screened at intake and referred to a variety of programs, including mental health and substance abuse treatment. The partners meet monthly to plan all in-jail, transitional, and post-release services so that treatment continues after release. An evaluation was done by the University of Pittsburgh, and it found that recidivism rates are cut in half compared to non-participants, and the program saved over $5 million annually. The Allegheny program and others like it, I think, are proof positive that we have the ability to improve health care delivery in our nation's jails and prisons, and to enhance public safety in the bargain, as well as saving money. So I'm excited about this moment. We're seeing a convergence of opportunity and innovative thinking in correctional health care. We know the challenges are big, but they're also within our power, I think, to meet. And in meeting those challenges, we can make a big difference in public health as well as in public safety. As Vera said in the report for its Prison Commission, protecting public health and public safety, reducing human suffering, and limiting the financial cost of untreated illness depends on adequately funded, good quality correctional health care. There's no question that the work each of you is doing is vital to a healthy and safe society. If we can add the community element, and the Affordable Care Act may give us the chance to do that, I think we have a monumental opportunity to really change. To make the Correctional Health Network something we can all be proud of. Thank you for the opportunity to be here, and good luck with the work. Thank you.